For for those of you who'd like to mark your calendars, we have an amazing next panel of speakers on April 23rd, when we'll be thinking about the assessment of learners. And our final session in this series is really going to reflect back on all of the discussions that we've had. And we will try to also think about what a future where medical education and informatics converge looks like. And so if you haven't registered for any of these sessions and you'd like to, please go ahead and do so at dbhi.chap.edu, and you'll continue to receive emails with links to the presentations. And also CMEs available for these sessions. For today's sessions, you'll receive an email after the session to claim credit at the email address that we have from your registration. So it also helps us there. But most important, as we start today, I just want to remind everybody that we would love for you to be part of the conversation. And so for those of you that have been here at previous sessions, you know that our chat is something that becomes quite interactive. And so please put any thoughts, comments, questions into the chat. And we'll maximize our time for discussion with our panelists today. So with that said, I don't want to spend too much time and really be able to dive into some initial presentations from our panelists. So I'm thrilled and honored to welcome three amazing panelists to continue the conversations we've been having. Our first presenter today will be Dr. Jill Posner, who's professor of clinical pediatrics in the Division of Emergency Medicine at CHOP and faculty medical director for the CHOP Continuing Medical Education Program. And then we'll hear from Dr. Lisa Dewan, who's assistant professor in the Division of Critical Care Medicine and the Division of Biomedical Informatics at the University of Cincinnati and Cincinnati Children's Medical Center. And she's also the program director for the Pediatric Critical Care Medicine Fellowship there. And then we will have our third presenter is Dr. Jeffrey Gold, who is a professor of medicine in the Division of Pulmonary and Critical Care Medicine at Oregon Health Sciences University, and also is a professor in medical informatics and clinical epidemiology. So without further ado, we will dive into our first presentation that's going to be shared by Dr. Jill Posner.
Thanks for that introduction. I'm honored and excited to have been asked to be on this panel and to discuss how we can integrate medical education and informatics to better support learners in our clinical practice. So all of us have different clinical practices, different specialties and expertise, different types of patients and practice settings. But I think it's fairly safe to say that most of us increasingly feel our clinical days look a little bit like this: multitasking in overdrive, so many responsibilities just to ensure the best possible patient care. And now add to that providing supervision to trainees and the responsibility of ensuring competency of the next generation of clinicians, the task can become really daunting. As a medical educator, I feel passionate about my role as a clinical preceptor, but it sometimes feels as though my teaching responsibilities can take a back seat to everything else I have to do during one of my clinical shifts. And even though the amount of clinical learning that needs to happen is growing exponentially, so is the amount of everything else that we preceptors need to do. So it's against this background that I approached my planning this talk. I spent some time pondering where are the gap areas in clinical teaching that an ongoing discussion and collaboration with informaticists might lead us to developing some really innovative strategies. So teaching and learning in the clinical environment is a huge topic, and after much consideration, I decided to focus on these three main conceptual areas: workplace learning and the challenges and opportunities afforded by the clinical learning environment, introducing a relatively new term or concept, the idea of health system sciences as a third pillar of medical education, and clinical decision-making and cognitive biases. So I want to talk a bit about the concept of workplace learning, and in our case, the clinical learning environment. There's been much focus in the last decade, especially within graduate medical education, on ensuring that we're providing the optimal clinical and learning environment for trainees. In fact, the ACGME makes clear visits, clinical learning environment review, as part of their credentialing processes every several years. Teaching in clinical practice is very different than teaching in other settings. In classroom learning, there's a two-way relationship between the teacher and the learner. It's very structured, very predictable, and follows a set curriculum such that all learners have a similar learning experience. In contrast, clinical workplace learning is centered on a triadic relationship between teacher, learner, and the patient. The purpose is twofold: take really good care of the patients and make sure that learning happens along the way. These are powerful learning moments, often occurring at the most unexpected times and in unexpected ways. It's all experiential. Learners get the opportunity to learn how to collect and access information, to synthesize it, to make decisions, and they get to see the results in real time. At the same time, the clinical learning environments are very unpredictable. Learner experiences are variable depending on the patients they're exposed to, whether they had the opportunity to perform a particular procedure, the time of year and the spacing of their clinical rotations, and whether seasonality affected the types of illnesses that they saw. As a clinical preceptor in the emergency department, I typically am meeting my students and residents for the first time, and I have only the next 8 hours to teach them, not knowing anything about where they are on their own learning continuum, what experiences they've already had, and conversely, what experiences they haven't yet had. What if we could start our shifts together using real data to chart our course for more deliberate, more predictable, and more individualized learning session together? It's important to note that this triad of clinical learning takes place within a larger, complex health system, represented by the yellow circle on this slide. This is my segue into the next concept that I'll briefly discuss, which relates to a new-ish area within medical education, the health system sciences. So increasingly, we're recognizing the importance of other determinants of health and health outcomes beyond simple diagnostics and therapeutics. These include the patient experience, healthcare delivery policy and economics, interprofessional teamwork and collaboration, population health, value in healthcare, quality improvement, patient safety, and others. As this healthcare landscape continues to evolve, medical education must also continue to evolve with an expanding set of systems-related competencies and an associated shift in the teaching processes and the assessment of learning within this context. In September 2020, in an article in Academic Medicine, Gonzalo et al. Offer a framework for medical education that places health system sciences alongside basic sciences and clinical sciences as the three pillars of medical education. This isn't to say that we haven't been teaching in the health sciences areas. We have. But this framework supports the development of a more unified and integrated approach to curriculum development, teaching, and assessment of the health system sciences competencies along the learning continuum. And this is an area that's brimming with opportunity for innovation and collaboration among educators and informaticists. And I hope we'll have a fruitful discussion more in this area. Finally, and switching gears now a bit to the third concept I'll touch on. So clearly the main competency that we're teaching in clinical practice is clinical decision making. And there have been huge strides made already in terms of informatics-based clinical decision support, pathway development, order sets, best practice advisories, and safety alerts. But I'd like to spend a few minutes talking about clinical decision making from the theoretical perspective, and hopefully this will become a jumping off point for even more discussion. For the last decade or so, there's been much work around how people think in making decisions. The dual process theory describes two modes of thinking, type 1 fast thinking and type 2 slow thinking. Both processes are used in clinical decision making, and there are advantages afforded by each, but there is also the potential for faulty decision making embedded with each of these two modes of thinking. So briefly, type 1 fast thinking uses pattern matching and heuristics. It happens quickly, less consciously, but usually quite effectively, especially as clinicians get more experienced. There are many times when it's critically important to rely on type 1 processes. For example, when I have a patient in the trauma bay, I'll assemble my team and quickly proceed through the primary and secondary survey looking for expected patterns of injury associated with the known mechanism. But if I go too fast or I'm unaware of potential biases in this thinking, I could miss something very important. For example, erroneously attributing tachycardia to anxiety or pain and failing to consider the possibility of occult blood loss. Type 2 or slow thinking is effectively used when faced with a patient with unusual or unpatterned constellations of signs or symptoms. It's more deliberate, more analytic, uses conscious reasoning. It might trigger more testing and data gathering than necessary, though, and therefore can become overly resource and time intensive. So neither type 1 nor type 2 are wrong. We need both of these processes for good decision making, but we need to maintain an awareness of where there's potential for error to creep in. Diagnostic error is operationally defined as a diagnosis that's unintentionally delayed, wrong, or missed. And this is increasingly the focus of preventable adverse events. Cognitive biases are a leading cause of diagnostic errors. And when we look at the processes that contribute to diagnostic errors, we see that primarily these result from faulty synthesis and not due to faulty data gathering or a lack of knowledge. Most arise from type 1 thinking, an over-reliance on pattern recognition and intuition. And we can use type 2 slow thinking as a self-check, so a form of executive override, if you will. We need to force ourselves to slow down, ask, have I closed in prematurely on one specific diagnosis? Have I considered alternative diagnoses? Am I using data to reinforce the decision I've already made, or am I questioning results that may not fit in? Much of the current teaching we do in clinical decision making is focused on our having a better awareness of the types of cognitive biases and then developing our own personal debiasing strategies. But I'd ask, are there better ways that are more integrated within our work stream, that are embedded into our systems, that can prompt and maybe even gently force debiasing strategies? A deeper dive into the path to successful debiasing might offer insight into where and how we can develop strategies to counter cognitive biases and strengthen clinical decision making. There's great opportunity for educators and informaticists to collaborate within this sphere. And I'm sure Dr. Rasooli will have a lot to contribute on this topic as she and her group are on the forefront of this work in developing the CHOP Center for Diagnostic Excellence. So I started out this presentation highlighting some of the opportunities and the challenges associated with teaching and learning in the clinical workplace. I touched on how, as medical educators, we're re-envisioning health system sciences as a third pillar of medical education, and we're looking for new and creative ways to teach and assess these competencies. Finally, I spent a few minutes taking a shallow dive into clinical decision-making and cognitive debiasing. I'm looking forward to our discussions on how we can integrate medical education and informatics to enhance clinical learning so that learning and teaching becomes a bigger and more seamless part of our providing high quality, safe, and effective care for our patients. Thank you for your attention.
Thanks so much, Jill, for that great presentation that I think really actually sets up our next two speakers very well. It looks like there's a question from Urit, who you mentioned in your talk. So she said, I think there are questions, your questions get to some fundamental questions, whether there are trade-offs in decision support and education. Do you have any thoughts about that piece in terms of like when those types of trade-offs occur, how one might think about how we design our care delivery systems around that?
Wow, thanks, Urit, for setting me up in that way. No, I mean, I think that is a really important question, right? So where's the sweet spot in helping trainees develop strong clinical decision-making skills, autonomy in their decision-making, but support. So I think the key word is clinical decision support, which is what informatics is providing. There is an art to medicine, and that art is embedded within humans and not computers. And so I don't have an answer of where the line between, the two lives, but I think that that's an important issue for us to think about, especially as we move forward in sort of creating some of these new and innovative strategies to support learners and practicing clinicians in our clinical environment. So no answer, but definitely agree with thinking strongly about this.
Great. All right, well, we will have more questions for all three of the panelists as we move forward. So next, we're going to hear from Dr. Maya Dewan discussing her work identifying just-in-time needs for learners.
Hello, my name is Lisa Dewan, and I'm a pediatric critical care physician at Cincinnati Children's Hospital. Today, I will be discussing how to use clinical informatics to support trainees in their care of the deteriorating child. I have no conflicts of interest to disclose. While we wait for trainees to develop competency, we provide support. We do this with procedures, anticipatory guidance, physical exam skills, etc. So why do we expect trainees to recognize, respond, and escalate concerns around deteriorating patients in an independent fashion prior to them developing the skills that they need? We really shouldn't. So how do trainees do identifying patients at risk for deterioration? Not surprisingly, the answer is not well. How do you recognize something you've never seen before? This table is from a study of an adult ICU in which trainee prediction of deterioration was only slightly better than the flip of a coin. Similar data has been shown in the prediction of deterioration for pediatric patients admitted to the general ward from the ED. Okay, so if the patient is pre-identified by someone more experienced or say an automated system, then how well does a trainee do knowing that the patient is high risk and what the plan might be? Again, the answer is not well. This is from work we did in which we evaluated the team's shared situation awareness. You can see that residents are more likely to not know the overall patient risk status or why they're at risk, and less likely than nurses to know the plan. Currently, less than 7% of pediatric in-hospital arrest in the US occurs outside of the ICU. So how do we identify these needles in a haystack and support trainees without creating alarm fatigue? Knowing that recognition of deterioration, especially due to rare causes, will take many years as faculty to develop, relying on education and supervisory trainees is insufficient. Instead, we must build a robust system of situation awareness to support all members of the care team. Situation awareness is the ability to monitor and recognize cues that increase the awareness of what is happening around you, integrate information to develop a comprehensive picture of the current state, and extrapolate forward to determine if the knowledge obtained will adversely influence the situation immediately or in the near future. For high-risk pediatric patients, both within and outside the ICU, situation awareness, or SA, allows one to perceive risk and understanding of the meaning of that risk, and then leads us to decisions and actions that can prevent deterioration. Systems that support trainee SA may often lead to the statement, I know something is wrong, but I can't comprehend, understand, or project alone. This is why systems of support are necessary. To support our trainees outside the ICU, we use this new SA model here at Cincinnati Children's. This SA model incorporates all provider roles, the family, the bedside nurse and RT, and the charge nurse. It starts with prediction, including gut feeling, parent concern, etc. The prevention component includes a bedside SA huddle where a mental model is discussed. If there is concern from the team, the patient will be made a watcher with a clear action plan and reassessment timeline. MRT or rapid response team criteria are also made. A bedside watcher sign is displayed outside the room and an EHR-based note and order are completed. The plan is communicated with the attending and the consultants. If there is immediate concern, the team escalates to either a code or a rapid response call. We built a new SA Navigator within our electronic health record. In the old Daily Review tab, we renamed it SA Daily Review and added an SA Concern section with our new icon, the lighthouse. Everything lives in this single location. Our SA guidelines, orders, acute event note with the SA template pre-populated, and even an opportunity to give us feedback. While we worried that a note and an order would lead to increased documentation burden, we settled on this workflow for a few reasons. The goal of the order is to be a quick and simple way to alert the full team, including on our institutional dashboard, within the nursing brain and within the SA column displayed for the full care team, that a patient is at high risk for deterioration or a watcher, and to help our trainees build specific criteria for when to call a rapid response. We give options of physical exam findings with prompts to help learners of what they should consider. We also include physiologic parameters, again with key components that we want them to consider. You will notice that we also include an attending notification button to try to reinforce the importance of that escalation, and an expected time to resolution to help trainees think about when this should resolve by, and when patients may not be following the expected trajectory. Lastly, we have kept in place an SA concern note because we feel that the documentation here is also important, though we have shortened it considerably. In addition to the note and order within the Navigator, other components of the SA huddle include the use of a bedside mitigation plan and the completion of the M2 checklist shown here. While these two components currently remain analog and not digital, we use them to help support psychological safety and encourage all staff to speak up. While there are multiple other components of this amazing system, the last key one I want to discuss is the net score. Like many centers, we had pews, which was commonly ignored and usually ridiculed. We spent a lot of time discussing and getting opinions on various vital sign-based tools, including complex machine learning algorithms. Finally, what we settled on was that we didn't in fact need an early warning score. With so few cardiac arrests outside the ICU, we have proven that almost all of the time we move children to the ICU prior to severe deterioration. We decided that what we needed was in fact a late warning score, one that would catch the few children each year with unrecognized vital sign instability who we could support and improve their outcomes. With that, we developed and are currently validating the NET score. NET stands for Notification, Escalation, and Trigger. I will let you in on a little secret. It's just an adapted pews, but the difference is we're looking to find the kids right prior to deterioration, and so we use a much higher cutoff. In addition, this helps to reduce false positives. We use a two-stage BPA similar to our sepsis work. When the pre-specified threshold is met, a BPA fires for nursing, asking them to recheck vital signs. If the number remains high, they are instructed to call an SA huddle. We are currently working on a validation for our more complex patients using rolling averages, and we look forward to sharing more in the future. In addition to prevention and support of our trainees on the floor through SA, we thought it was important to support the ICU teams, given that that is currently where the majority of events happen. Our rework of our ICU SA process has been occurring over the last 5 years and was the example from which the floor work was built. We adapted the system that I helped to develop from a paper checklist at CHOP to a CDS tool. This tool is an automated evidence-based passive alert that helps to track the high-risk patients in the ICU. We are currently building similar systems for our NICU and CICU, and these notifications incorporate patients for which we have concerns and result in a bedside huddle. In addition to automated criteria, we also now have a manual entry built to allow for concerns such as provider intuition or around procedures. This information also filters into the institutional-wide dashboard and into the nursing brain workflow as well. To make this tool successful in improving situation awareness, we can't just perceive and comprehend the risk, we also must anticipate and create action for prevention. We worked with a multidisciplinary team, including our Family Advisory Council, to develop signage for the doors of our high-risk watcher patients. The signs identify the potential risks, included the automated as well as the non-automated risks. In addition, they include the first few steps to intervene and prevent deterioration. The goal is for the nurse to be able to respond while calling for help, to have the medications and orders he or she needs before the event. In addition, this is a visible sign and structured process that helps to support our resident and fellow trainees. To review our process, a patient is predicted as being at high risk for cardiac arrest through our automated situation awareness tool that continuously screens patients, or due to other provider concern is identified during our twice daily safety huddles. Once identified, each patient has a quick bedside watcher huddle to review the plan and complete the sign. If a patient remains high risk or a watcher for multiple days, the sign is updated on rounds or as needed. We also use pod-based huddles or puddles because our unit is broken into many smaller units. This work has real implications for our patients and our trainees. We have seen a decrease in emergency transfers with our floor SA work. This has also resulted in a sustained decrease in CPR events in the PICU, with 16 less children experiencing CPR in the last year due to our work. I could talk about this work for hours and give many more details, including discussing our sepsis and other ICU-based SA work. However, I'll stop with these few key learnings. When patient deterioration leads to a bad outcome under the care of a trainee, it's the failure of our system to predict, prevent, respond, train, and recover them. We can't continue to yell at the moon for people to be smarter or to have more exposure. We need to build the systems around them that support their education and optimize our patient outcomes. I want to thank everyone that I work with here at Cincinnati Children's, and I'll take any questions you guys have now.
Thanks, Maya. One initial question that I had, even ahead of our sort of panel discussion in thinking about this work, I think would be, knowing that some of this sort of started as attempts to identify some just-in-time opportunities for training and education, I'm curious, as you sort of think about the support layer, are there opportunities that you all have explored to preserve some of the autonomy in decision-making and try to, make these sort of optimal learning experiences for your trainees as well?
Yeah, definitely. So I think there's sort of a multifold to that. So initially, the actual making of the plan in the huddle is led by our fellows. They do that independently with whoever, whether it's a nurse practitioner or a resident, the bedside nurse, and the respiratory therapist outside of attending presence.
then those signs are only reviewed by the attending, structured in a way on rounds to give them the opportunities to sort of form those. We've also created a lot of other support systems that help both our nurses as well as our trainees around, the usual order sets, notes, but we also have a lot of goal-directed sheets to help people determine, okay, for this particular kid, where should I be setting the blood pressure? What should the goals be? And enabling them to feel that support. In terms of just-in-time training, we actually just set up a brand new simulator and have scenarios for each of our watcher criteria. So for our most common reasons for deterioration within the ICU, when a patient reaches those criteria, we have actually 5-minute just-in-time training set up that we'll start to do as we transition into our new critical care building to help support and try to decrease some of those high-frequency events.
That's great. Yeah, and it seems like the interprofessional nature of your work is also a running theme across our panelists today, so maybe we'll also get a chance to dive into that during the discussion with the whole panel, but wanted to take this chance then to share the presentation from Dr. Jeff Gold, and then we'll pick up with the whole panel.
Okay, so thank you very much for giving me the opportunity to speak today. I'm going to be talking about how high-fidelity simulation training can be used to improve utilization of the electronic health record. I receive all my funding from AHRQ. I have no commercial financial disclosures. So numerous studies suggest that physicians and nurses feel that their current EHR training is inadequate, that current training is context independent, meaning we all just sort of get this point-and-click training right when we start, and it doesn't matter if you're a pediatrician or OBGYN or internal medicine, and that most of the optimization stuff that's done afterwards is focused on data entry, meaning how can you effectively or efficiently create a note. Simulation is an ideal way to train and ingrain new habits and understand systems in general. And simulation is considered a necessary and key component to EHR in training and design. And when we do training with the EHR, it needs to be to task. And so this was an article that came out last year in PLOS One, which basically shows that if you look at just internal medicine residents, that while they spend a lot of time not only with the EHR, as we know, they spend actually the majority of their time on chart review, not necessarily on note entry. And so when we come up with training activities for them, it can't be just about the efficiency and how to create a note as quick as possible. It has to also focus on how to effectively gather information out of the EHR as well. And so our group at OHSU has developed an EHR simulation training environment to help teach these skills. We are an Epic shop, and we take Epic, we clone it, and we put it on a separate server. So we have actually 9 different clones of Epic floating around. It's our multiverse. And that we then create specifically designed cases which are created once and then can be cloned and time shifted and teleported out for storage. So in the simulation environment, we have our own simulated charts, and we can move them around and shift them forward and backwards in time for the day of training. We rebirth our simulation environment every 3 to 4 months to update the health system changes and user customizations. So you're working with about as up-to-date of a system as you can. And then the cases are then readmitted to the simulation environment after each rebirth so that we don't lose them. When we design these simulation cases, the cases need to be designed for the learner group, the educational activity, and the desired outcome. Meaning is different type of cases that you use for a first-year medical student who's just learning Epic versus an attending, versus an inpatient versus an outpatient physician. And obviously the specialties are different. The charts for pediatricians are different for emergency medicine, which are different than orthopedic surgery. Ideally, the content is created to ensure you can assess not just efficient use, but effective use of the EHR and learner decision-making. For example, we will build our charts that will have blood pressure changes on an inpatient over 36 to 48 hours. So this assesses our ability to not only find and trend data, but what decisions they make with that data. And that you need a standard rubric for design element and standardized data entry cookbook in order to help put this information into Epic. And that's something I'm not going to talk about in this presentation, but we actually have this entire template to ensure that each simulated case has all the desired elements necessary for effective education. So the questions are, does this actually help improve performance? This was a study we published about 7 years ago now, where residents who are already rotating in the medical ICU, in the afternoon after rounds, we pulled them aside and we gave them a simulated EHR chart of an ICU patient. We gave them 10 minutes to review the chart, and then we had them present the patient to us. The chart had a number of patient safety items built in that we needed the residents to recognize. These would include things like lack of best practices, like missing DVT prophylaxis, a trend in blood pressure going down, missed dose of a medication. The residents were graded on the percentage of these items that they got correct. Then when they came back to the ICU on a subsequent rotation, they repeated the exercise with a different simulated chart. And what you could see here is that overall, everyone's ability to recognize these patient safety items improved. And it didn't matter which of the charts they started with. So the charts were not only equally complex, but it didn't matter. Both charts served as a nidus for learning better EHR skills when they then got tested on a repeat chart. And this figure, I think, is the most telling from this paper, which is that here is the overall percentage of items that were correctly identified. As you would expect, interns did a little bit worse than PGY2s and PGY3s, but interns and residents who went through testing once, on the repeat performance, when they go through the simulation for the second time, so they've had simulation-based education, they outperformed our critical care fellows going through it for the first time. So again, you could teach people how to better effectively navigate the EHR and recognize patient safety items built into these cases. We've then said, well, wouldn't it be better to start hitting the residents before they get to the wards as opposed to months later when they're already in the ICUs? And so at OHSU, we have an internal medicine boot camp that we run in August or September every year. And as part of that boot camp, we have a dedicated session focused on learning EHR skills. And now this is different than their onboarding that they get before they start. But in this session, we're given 2 hours, which is not a lot, but it's the best that we could do. And in there, they have 1 hour we spend showing them how to effectively navigate an EHR chart using one of our simulated charts. And we have a set script that we go through with them. After doing this together for about an hour, they then are given a little bit of a break. They are then given a second chart to review. They are given about 20 minutes to review that chart. And then we go through and debrief on that chart together of all the items that were missed or that were present in that case that they should have recognized, and showing them how to best use the system to recognize these issues. In other words, how best to look at data trends over time. When the residents are doing their independent portion of the activity, we actually use screen tracking to see their navigation patterns. So we could actually see, are they using the screens that we told them they should use? So these are data that were just published a couple weeks ago in JMIR. So overall, the residents, this is 2 years worth of data. The residents were highly or significantly satisfied with the session improving their skills. This was immediately after the session. They all found that the activity was useful, and they all found that the activity was enjoyable. In the bottom panel, you could see here we want everything, this is a Goldilocks figure, we want everything to be about a 3 or just right in terms of how difficult was the independent portion activity. All about just right. How difficult was it to follow along? Most of us gave us about a just right. And how was the pace? Just about right. Now this figure is a little bit more complex, so let me walk you through it. This is now looking at what was the impact of our session on the screens that they used within EPIC. And we have 3 cohorts of learners here. In gray are people that were tested while they were in the ICU. That first slide of data I showed you. We actually also tracked which screens they navigated. So the gray is what people are using in the ICU de novo on their own after basically learning through trial and error. The blue bar is the percentage of learners that use those specific screens during the independent learning portion of the simulation activity. The red bar is when we surveyed the residents 6 months later, 6 months after the boot camp, what percentage of them were using these screens still. And as you could see, on the bottom are the individual screens within EPIC. You could see that overall, that the blue bars, that people were using the screens during the independent learning portion of the activity more than what they were de novo. And some of these screens, which were very, very high yield, such as being able to trend results with a graph or a table, were hardly ever used by residents on their own. They use it during the independent learning portion of the activity, and it seems to be sustained at least at 6 months based on their own self-report. So now at OHSU, we've really taking, this is part of an initiative called 2025, where we are restructuring and reinventing EHR training, and we've divided EHR training into 4 levels. 1, could you use a computer? 2, the basic buttonology of EPIC. Do you know where the results are? Do you know where the progress notes are? Do you know how to start a new note? This is the general EHR training. Level 3 training is this workflow-specific training. In other words, can we teach you how to round on an ICU patient? Can we teach you how to do an admission for our general pediatrics admission? And for that, we use these high-fidelity simulated charts. And then level 4 training is, which I will not talk about in this talk, but can answer in the panel, is how we use this to actually help struggling learners to understand where they're having problems and come up with prescriptions to improve their performance. And as part of this at OHSU, we are now taking this simulated training that we do for internal medicine and going to apply it to all the primary residencies in this summer. And then after that, this will be then mandatory for all new employees, both attendings and residents and fellows in 2022. So in summary, EHR simulation with cases specifically designed for a given specialty can assess and train for EHR use in clinical decision-making. We can actually make it fun and enjoyable, which is sort of like saying school lunches taste well. And that the EHR is uniquely suited as a conduit for remote and asynchronous learning. And we've actually been able to do this asynchronously in the setting of COVID. And while it works almost as well, there are some limitations, which again, I could talk about in the panel. And these are just some of the collaborators that work in this group. And I think I will stop there.
Great. Thank you so much, Jeff. It's really interesting because it seems like the concept of like cognitive debiasing and effective decision making is something that really overlaps across all of your presentations. And so maybe one high level place to start the panel discussion is, I'm curious for the 3 of you, can you talk a little bit about what does a future look like where we have these human technology systems that are going to do better from that perspective?
I don't know. It's a great question. I think the one thing that I've learned, especially dealing with struggling learners, is we have forgotten how to teach the basics. And until we make sure that we teach the basics of what information needs to be gathered and why and what to do with it, the technology, I guess the way to put it is that It used to be when we were on paper, we taught people not only what information they needed, but where to go find it, because those two things went hand in hand, because everything was in different places, right? You had to go one place to get the labs, one place that you had to go actually talk to a nurse. Like God forbid you actually could, you couldn't just read a note. So now what we do is we teach them where all the information is, and we assume that if they know where the information is, that they are finding the right elements. And it almost has to be, the way I give it is, we have to go back to almost a physical exam for data and information, meaning that you have to have a structured approach as to what information you need to find, what questions you need to ask on each patient every day, and then you can figure out what tools are best used to help you achieve that goal. Instead, we're doing the exact opposite. We're teaching them, here are all the tools, and we assume that once you use those tools, the information will become self-evident. And I think that as long as we have that cognitive gap, we are going to continue to make mistakes. And this is what we do in the level 4 training, actually. It's what I call residents who are data whisperers, that they go to all the right screens and they scan and hope that something will just magically pop for them. But of course, the only stuff that pops is based on their inherent cognitive bias. And the way that we can actually get at this is we use eye tracking, so that when they're navigating the chart, we can actually see not only what screen they're on, but very specifically every single cell and data in Epic that they look at, and in what order they look at. And then we can have them debrief their own performance. And that helps with the cognitive unbiasing, because they actually are forced to see how they are cognitively processing information in real time. And I could show an example of that if people are really interested at the end and see little red dots floating on the screen.
Great. Yeah, thoughts from Jill or Maya? I mean, this seems, Maya, to overlap a lot with how you sort of think about perception in situation awareness in your work.
Yeah, I think we still struggle with, as you well know, the measurement of many of these things to find our true gaps. But the support, again, to go back, the sort of what we've been harping on of the interdisciplinary support of the team enables any particular member to make a mistake, and that's okay, right? So if you're supporting every member of the bedside care team to the highest level of support, then it just gives a little bit more wiggle room for the trainee to ask questions or be uncertain. It gives a little bit more room for the newer bedside nurse to have not seen this or experienced this before. So I think it's that integration of the automated support to help people not miss, create that safety net like we talked about for the floor patients, but at the same time, drive them to work together to find the right answer.
Yeah, I love this quote that you said, Maya. You said, how do you recognize something you've never seen before? And I think that the record, the electronic health record, is such a rich source of data for learners in terms of their, having data that indicates what have their prior experiences been, what have they seen before, what haven't they seen before. I was talking with Ann Ades, I'll call you out on this a little bit, Ann, but we were talking the other day. And how about when someone puts in orders, this was Ann's idea, someone puts in orders for lumbar puncture results, so that the orders for the testing, and something comes up and says, you have done 3 lumbar punctures before. And as a preceptor, you can say, oh, wow, that's maybe not enough. Maybe you haven't done this quite as much as I thought maybe you had. And then that could link to, various teaching modules about lumbar puncture and things like that. So I don't think that was exactly your question, maybe, about cognitive debiasing, but this all helps us to understand, what do people know, what don't they know, how do they access the information, how do they organize the information, and then sift through the information to come to the most accurate decision making. So those are some of my thoughts there. And I also do want to just shout out, I do really love the thinking that we're having about teams and teamwork and how we can support not just our medical learners, but really the whole team of learners and practicing clinicians.
One of the things, Maya and Jill, which I think is that I've started to notice in my research and work around here, is as things have become more interprofessional, I've seen, the whole idea of a safe, right? We all talk about the Swiss cheese model of patient safety, right? And the whole idea is that, there's certain holes that make their way all the way through the cheese and go all the way through. And the idea of interprofessional work is that, as I always joke, is that it should be cheesecloth, right? So the idea is something makes it through one layer, the physician layer, the pharmacy layer catches it, right? But what I've started to notice, like from when we do our EHR simulations, is that as we are getting better at integrating all the professional groups into our daily work, what we've also done is now siloed information away from professional groups that don't take ownership over it. So, for example, in our simulated charts, we have medication dosing issues with antibiotics and renal function. And we don't expect the residents to necessarily say, oh, I would change the dose from X to Y. We expect them to recognize the renal functions change. We probably need to at least ask somebody, do I need to change the dose of antibiotics? When we started this 5 or 6 years ago, or 8 years ago now, about half the residents would recognize that issue. It's down to 0 now. The residents don't even bother looking at that anymore. And what's interesting is when we test the pharmacists, they don't get it right 100% of the time either. So we're now creating a separate cognitive bias in essence, which is that we now assume, I think the physicians will assume, that every decision the pharmacist makes around medication is correct, which I think is also a false assumption because they have their own cognitive bias. And we've published some stuff on how they miss stuff, that not one medication error in any of our simulated charts when we take the pharmacist through do 100% of the pharmacists get right. So I think that's going to have to be also something we have to make sure that as we get to interprofessional work, that we make sure that we don't tell our trainees, don't worry about the pharmacy. You still need to know this. Your job is to, the safety net is that everyone has some knowledge base, not this that you've outsourced the knowledge base to another group.
Yeah, I think that's a great point, Jeff. I've spent the last year of my life fixing things that got uncommunicated when we switched to the nursing brain approach within Epic to make their task workflow easier, realized that it didn't integrate with any of the other safety mechanisms that we had built, and so have had to go back and do that and come up with ways for everyone to see the same information in a similar way. And I think that's why some of the key components of our essay work remain analog, because the sign on the door is visible to every single person who walks by the door, and it doesn't matter who you are. It's the parent, it's the desk clerk, it's the person bringing in the food. It's everyone knows what that sign says and what they're looking out for. And then that's also why we've sort of wrapped up with that checklist to make sure that everyone's on the same page, because when the information is presented to you in a very tailored and unique and catered fashion, it is hard for everyone to see how conclusions are being drawn differently across disciplines as well. So I completely hear that and agree as well.
So communication is such a big part of effective teamwork and collaboration. And so now we need to add in communication among team members verbally, and now communication among team members within our electronic methods. So that's really an interesting quandary that you informaticists are going to have to figure out.
The other thing I did want to ask about, Jill, I think you used the term at one point talking about sort of creating predictable learning opportunities. And it's really interesting to me that both Maya and Jeff in their work actually, are setting up simulations that are accessible in the course of clinical care, or pulling people during their time in clinical care to provide these interventions. And so I'm curious, like, it almost seems like you're thinking about simulation and some of these other methods as well as this sort of like hybrid real-time model, right, that would be accessible to people. And so I'm curious if folks have thought about that as like a broader approach in other contexts as well. Being able to predict learning opportunities rather than predicting deterioration or whatever. We often try to on the clinical side, and then having a maximally effective learning mechanism to be able to have people use over the course of clinical care.
Yeah, I don't know that I meant to say that we could predict the actual learning opportunity, but I think we can be more deliberate in the learning experiences. So, as it stands now, I'll only speak about my own environment. Whatever patient is up next is the patient that the resident goes to see. But what if we were more individualized about that? What if we were more deliberate about trying to ensure that the clinical experience that our learners have is really integrated with their own development and where they are on their own continuum. And so to the extent that we have more knowledge and more data on where, not even outcome and assessments, but just experiential data, we could help individualize curricula towards the individual learner. And that's sort of what I was looking for. And I know you're doing a little bit of that, right? Aren't you starting to do a little bit of that with the Trails project? Or do I have the wrong project in mind?
No, I mean, yeah, I'll defer. I think Mark Mai put a comment in the chat and can share more about that.
Sorry, I've been bouncing back and forth between stuff with the baby, but so yeah, I think your talk sort of resonated with that, Jill, in that the Trails work, we can identify the data pretty easily pulling it from Epic in terms of what trainees are experiencing, but I think larger than that. And sort of what you all are touching upon is creating an educational scaffold, right, that is individualized to the patient, individualized to the learner themselves, right, and figuring out how to effectively mesh those two. Oftentimes, the biggest conversation I've had with residents and their comment is that they just sort of expect to learn things via osmosis. And I think, like you're talking about, Jill, being a little bit more deliberate about saying this is what you've done in the past, this is where we need to go. How do we actually do that? I think we can start to build those tools, but I think we need to be deliberate about how we use those things.
I don't know, Mark. I don't know if this is your guys' work. I thought maybe it was Hopkins, but maybe it was you guys, that there was a paper that came out about 4 years ago. I remember the author, where they used basically EHR audit logs to then look at case distributions for different residents. So like how many HIV cases they've had, how many liver failure patients they've taken care of, et cetera. So that is something which I think is going to be part of the future as well, so that you could then start saying, okay, we got 4 new admissions, 2 cirrhotic. I'm sorry, I'm an adult medicine guy, so like these are like everything for you guys is croup from what I know. And so, I got like Steve, you've had 4, you've seen a ton of cirrhotics and no HIV patients, so you're getting the HIV admission. I don't care who was up next. We're redistributing these patients based on the stuff that you have and haven't seen. I think that's sort of next level of being able to use that data.
Yeah, and I think people are just starting to dip their toes into the EHR audit logs to look at some of those experiences. And our group published on that in Applied Clinical Informatics a couple of years ago. Danny Wu and Dan Schumacher out of Cincinnati have also published some work doing feasibility work. But like you're talking about, I think the general scope of medical education at the graduate level right now, people don't really have a sense of like what are our trainees actually seeing in comparison to what we're expecting them to see, and what they expect to see at the end of their training. And so I think, like you're saying, this is the future of that work, towards more precision and personalized education.
We are nearly at the top of the hour. I'm going to see if I can sneak in one more question. Mark, while we're doing that, there's a request for the baby to be visible. So the last piece that I'll ask is, you all mentioned this idea that, the electronic health record is siloing some of this communication and challenges here.
Maybe.
Curious if there are ways to think about reframing that so that the displays in the electronic health record are not just about just providing the information, but maybe akin to what your situation awareness work, Maya, shows around sort of the actual helping support comprehension and projection, even if it's something that they've never seen before.
I totally ignored your question because I was enthralled with the baby.
Totally fair. I think the baby wins. But the question was basically, are there ways we could sort of think about taking the kind of work that you and Jeff and others are doing to reshape the displays in the electronic health record to not just be about the information perception, but actually to support comprehension and projection for something that maybe you've never seen before, ever?
Okay, so I'm the worst informaticist because I always feel like you should get the hell out of the electronic health record, right? And to the bedside. So it makes me a terrible informaticist. But I think one of the things that we found ourselves doing is structuring communication between humans, because we have actually done a decent job of structuring data. So I showed you in our development of the essay navigator, one of the things was people didn't understand the workflow. They didn't understand what they were supposed to do. So we put everything in a row, in the order that we wanted people to do it in, right? And so we said, do all these things. And now they do all those things. They were doing it great, but they weren't telling anybody about it. So it was every checkbox that we wanted in the electronic health record because it was highly usable, it was efficient, it was short, it was that kind of stuff, but it wasn't actually impacting the patient care, right? So I think the way that we bring those things together, and I think the key is going to be how we display and present data to people while they're caring for a patient, not while they're rounding or looking at a screen, but what data do I see as I'm looking at the patient? What is displayed around the patient? Where are there opportunities for me to share imaging with the family or the team in the room? And how do I sort of integrate those two worlds in a way to improve my communication? So I think currently that's where we're lacking. I think we can make the EHR more beautiful, but I think the answer is really to get people out of there and back to the bedside.
And I guess I'll add in on there. Three things. One, as long as we are doing this based on our gut feeling and not with a structured scientific usability approach, we're going to screw it up. I mean, we could blame Epic all we want and Cerner all we want for the way they display data. They didn't do it intentionally just to piss the hell out of everybody. They did it with their best intentions. The problem is that the goal of simulation is to actually be a test bed to help system redesign as well. So you need to have the cases, you need to have the simulated charts where you know what the data, you know the outcome, right? You know what the chart is supposed to be about. Then you could use that to test and do A/B testing with different displays. None of the vendors do that, and most of the institutions that customize their display don't do that either. The second thing is that, and it's something that we are working on here at OHSU, is changing the way in which we use the computer on rounds so that we don't do asynchronous stepwise data gathering. So we published a few papers in critical care medicine where we looked at what the residents told us on rounds versus what was on the piece of paper that they generated from the EHR versus what was in Epic. And there's a huge loss of information at each step along the way. It has nothing to do with how important the information is. It had to do with what information they felt comfortable processing in their own brains. So this idea that should we get rid of this whole idea of pre-rounding and that we all go through the data together as a group. And we've created sort of a mobile computer with multiple screens that we're testing out to do this. We call it the Holy Cow, but which I know is inappropriate, but the golden calf was the prototype. So we're offending everybody. So anyways, that's another way as well, but I will just be steadfast in that you use simulation to test and develop every new electronic device, but we don't do it for the electronic health record, which is the only device that is used by every single healthcare provider in an organization, and we have to have that same standard. We do it for a surgical clipping machine, but we don't do it for the EHR.
Great.
Sorry,
well over the hour. No, I think this is all just immensely valuable, and really enjoyed the discussion today, and really enjoyed seeing the baby today. So thank you, everybody, for all of your contributions. For those of you interested in hearing more about Mark Mai's work, he will be a panelist on our fourth panel. So again, please do keep an eye out for those emails. Thank you to all of our participants for all the great discussion, and please keep an eye out also for CME emails and fill that out to claim credit. Thanks everybody for joining.
Thanks for organizing, Naveen.
Thanks everyone.